Hey everyone, it's Olivia again from the New England QIN-QIO. We're going to go ahead and get started. I'm going to mute all of the participant lines just so we avoid any background noise. Once I do that, you'll hear a command that your lines have been muted. If presenters only could just make sure to press #6 to unmute themselves, that would be great.
Am I a presenter technically?
The leader has muted your line. To unmute your line, press #6.
So all lines have been muted. Tim, I did hear you right before we started. You are a presenter, so if presenters could press #6 to unmute themselves, we'll go ahead and get started. Good afternoon, everyone. Again, as I said before, my name is Olivia Hensey from the New England QIN-QIO, and I'll be your moderator for today's webinar of Self-Measured Blood Pressure Program. Is it right for your patients? The Quality Innovation Network Quality Improvement Organization works with healthcare providers, stakeholders, and communities across New England on data-driven quality initiatives to improve patient safety, engage patients and families, and improve clinical care at the community level. Thanks for joining us for today's webinar. Before we get started, just a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. As I said before, the phone lines will be on mute for the duration of the presentation. We'll take questions at the end, and I'll provide you instructions on how you can ask a question over the phone, or you can pose a question in the chat box anytime. Just make sure to send it to all participants. So at this time, I'd like to introduce our host for the webinar, Georgette Verhelli. Georgette obtained her associate's degree in nursing from New Hampshire Community Technical College and later went on to obtain her Bachelor of Science in Nursing from Franklin Pierce University. She has more than 30 years of experience in healthcare and has been doing quality improvement work over the past 5 years of her career. She is the New Hampshire State Lead for the Cardiovascular Initiative and the Quality Payment Program. Georgette, the floor is all yours.
Great, thank you, Olivia.
Thanks, Georgette.
So we're going to be talking about a self-measured blood pressure program. Is it right for your patients? If you could go to the next slide, Olivia, I'd appreciate it.
I actually just passed the ball to Adriane. Thank you, Adriane.
Okay, great, thank you. So Adriane, it's up to you to move on for me. So the New England Quality Innovation Network Quality Improvement Organization is brought to you by two different companies, Health-Centric Advisors, which focuses on Maine, Massachusetts, and Rhode Island, and Qualidine, which covers Connecticut, New Hampshire, and Vermont. Next slide. Great. You can visit our New England QIN-QIO website at www.healthcarefornewengland.org. And the next slide, please. And this just gives you, when you go to the website, this gives you a little overview. You can see we've got care coordination. We've got home health highlighted. Physician offices is also at the bottom of that list. There is also a macro tab that you can click on. Next slide, please. Great. So this just highlights a little bit more about home health and the different events that are coming up. Gives you a little view of what the website looks like. And we're all here to help you. These are your home health contacts in all 6 states, and they also are your physician practice contacts in most instances. So if you need to get a hold of one of us, just please reach out. We're here. Thanks. Next one. And finally, I just wanted to touch on the self-measured blood pressure program and the merit-based incentive payment system. NIPS-eligible clinicians can utilize their work in educating staff and patients on self-measured blood pressure monitoring to earn points towards their overall NIPS performance. So the quality measures that this falls under would be controlling high blood pressure and also hypertension, improvement in blood pressure. Under the improvement activities, we also talk about the use of certified electronic health records to capture patient-reported outcomes, and then also the engagement with the Quality Innovation Network Quality Improvement Organizations to improve and implement self-management training programs. I also want to add that since home health is already in the home, it's a great opportunity to initiate the self-measured blood pressure program with your patients, as it can lead to improving the quality of life, improve clinical outcomes, and also reduce acute care hospitalizations. And it can tie right into your quality initiatives. Next slide. And with this, I'd like to introduce Adriane Burke. Adriane is a program planner at New Hampshire's Division of Public Health Services focused on health systems, quality improvement, and hypertension control across the state. Adriane holds a master's degree in public health and is currently pursuing a certificate in value-based healthcare from Dartmouth. She has been working in public health for the past 10 years. Adriane?
Good. Hi, everyone. Thank you for joining us today, and thank you, Georgette and Olivia, for organizing this webinar. I'm really excited to talk to all of you about self-measured blood pressure monitoring and what we've been doing here in New Hampshire, along with the Quality Improvement Organization. So I thought it would be best to start with some of the basics. As most of you know, SMBP refers to a person measuring their own blood pressure outside of the clinical setting, usually at home. And it is an effort that has strong evidence behind it and is being promoted by multiple organizations across the country, both national and government organizations. And I'll talk a little bit more about their recommendations in the later slide. So why is SMBP being promoted? There are many reasons, but one of the main ones is that it's to help control blood pressure. It's also very valuable in improving adherence to antihypertensive therapy. So looking nationally, about 1/3 of Americans have hypertension, and about half of those are not under control. And then looking more specifically here in New Hampshire, and this data is specific to federally qualified health centers in New Hampshire. So these are patients who are already being seen by a practitioner. You can see that about 1/4 of all patients seen at federally qualified health centers have hypertension, and then about 1/3 of those are not controlled. So that leaves a lot of room for improvement, and we're hoping that SMBP is one way to help get more people under control. So here are some of the recommendations. The community guide recommends SMBP when used alone, and definitely recommends it with additional support. The Agency for Healthcare Regulation and Quality also did a comparative effectiveness study in 2012, which supports the use of SMBP, and the USPSTF also supports it. And what's important about this, and the recommendation is a little bit different, so it's not just directly SMBP for anyone who has hypertension. But USPSTF recommendations are required to be covered by health insurance companies, ones that have an A or a B recommendation. There's also a joint scientific study by the American Heart Association, the American Society of Hypertension, and the Preventive Cardiovascular Nurses Association that encourages the use of SMBP by patients known or suspected to have hypertension as a way to increase engagement for patients who are able to self-manage their condition. And then we also have organizations such as the American Medical Association, the American Heart Association, and CDC 618 initiative that support the use of SMBP. So here in New Hampshire, we saw a need, and we had plenty of people asking us about using SMBP in their clinics and seeing if we could help support those efforts. And we knew that insurance coverage for monitors was spotty despite the USPSTF recommendation. And so we were able to obtain some funding to purchase monitors, and we partnered with Georgette at the New England Quality Improvement Organization to help implement the program. And we're just starting to get some of those results back, which have been really exciting, and I'll talk a little bit about that in a further slide. So when we initially started, we looked at clinics who were already doing hypertension quality improvement projects, mostly with the state, but a few who weren't working with the state. And each clinic had to apply and be accepted into the program. The monitors were sent to clinics in September of last year, and then let's see, once they had their monitors and they developed a procedure manual, they were able to begin handing out monitors. So one thing to know is that each program did not start on the same date. Each clinic really started when they were ready to. So our results are starting to roll in now. We have 13 clinics participating. And so some of the requirements for participating in the program was, as I had already mentioned, each clinic had to develop a written procedure which outlines their program and how they were going to meet specific requirements. And we really encouraged a few different guides that were available to us to use as sort of an outline or guidance. One is the Million Hearts Guide on SMBP, and the other is a Johns Hopkins and American Medical Association guide. And then, so in addition to developing a written procedure, clinics had to identify patient education materials, and then they had to report back data to us at 6 months and 12 months. And as I mentioned, the 6-month data is just starting to roll in now. And here are some of the guides that I mentioned in the last slide. They've been really helpful to the clinics who are participating. So if you're interested in doing a program at your clinic, I'd highly encourage you to look at these. They have great resources and information. So here's some of our 6-month results. Mid-State Health Center, they've had 34 patients enroll. 25 of those have had an improvement in blood pressure, and 16 of those patients now are below 140 over 90. And with Goodwin, we also saw some really exciting results. 26 patients were enrolled, 20 patients have received have an improvement in their blood pressure, and 14 are now in control. And these numbers they just came in, so I haven't verified them, but they're really exciting. And so we're going to be starting phase 2 soon. We're still trying to figure out exactly what it's going to look like, but we're hoping to send out applications late in the summer or early fall. If you're interested in participating, please send me an email and let me know that you're interested, and I'll make sure to add you to our contact list. And thank you. Here's my email address and my phone number if you have any questions. And Georgette, I'll hand it back over to you.
All right, Adriane, I think you can pass the ball to Jen Adams next.
I think it's Jen Gullison.
Oh, okay, sorry. Thanks, Olivia.
No problem.
So my name is Jennifer.
Yep.
Hi, Jen.
And I'm from Cornerstone CNA. We do home care, hospice, private duty, and we wanted to implement this program to a home care setting, which is a little different than a clinic setting. And some of the reasons that we wanted to do this is because, like most agencies and physician practices, it's all about best practices and patient engagement. We wanted to improve accuracy for blood pressure monitoring by our clinicians. We wanted to increase the knowledge for clinicians on the importance of a self-measured blood pressure program specific to patients with unmanaged hypertension. And we wanted to improve patient engagement for blood pressure monitoring. And in the home setting, it's a unique position for clinicians, not only nurses but therapists, to increase the engagement, to improve overall numbers, and to make lifestyle changes. So implementation, we implemented this, as Adriane said, we applied for the grant last year, and we implemented it in the fall. We received 20 blood pressure units, and we had to develop a procedure for the program and assign a lead person. So our lead person, we have other programs for technology, including a comprehensive telehealth program, and that clinician that oversees that program adopted this, and she oversees all of the monitors, including assigning them out, tracking them, making sure we get them back, and then at the end of the program, determining whether we're going to give it to the patient for continued success or whether we're going to get it back and just use it as a loan unit. So with the implementation, there was work, part of this grant, that you had to develop a very specific protocol and procedure. And we really went through that and there's a very specific inclusion and exclusion criteria. One of the biggest things for home care is the patient engagement piece. So the patient has to agree to monitor their blood pressure at a minimum of at least daily. They have to record the results on a log that the clinician brings out to them when they bring the unit out. There's also a consent form that patients sign. So again, we want it to be accountability, and we want the engagement piece and the patient to participate in the program. So they're logging their vitals daily. They're recording them. The clinician then sends that log to the physician weekly for the communication. Makes adjustments with the goal of adjusting medication as needed to get that therapeutic results. And then at the end of it, really we need to support a case if we're going to give this unit to the patient. You know, what are the socioeconomic factors? Can the patient afford the unit? And then giving the patient the resources of where to get a reliable unit for continued results. And some of one of the barriers for the ability to get multiple units out, we haven't had a lot of patients on the program, specifically because we have a robust telehealth program, which has a scale and a blood pressure monitor, a pulse ox. So a lot of times the hypertension is the underlying diagnosis and not the primary. So we've recently actually changed our inclusion criteria to include more cardiac diagnoses, not specifically just uncontrolled hypertension as a primary diagnosis. And resources, the other part of the grant was developing patient education. And I worked closely with the physician practices in our area specific to the Million Hearts campaign and came up with universal standardized education brochures that we give to all of our patients. And then when we bring out the unit to the patient's home, we also bring out education, visual pictures for the patient so they know how to accurately take their blood pressure, so it's accurate readings. And it really is about best practices that we're giving to our patients that are standardized so that everyone's following the same protocol. And on the consent form that patients sign to be part of this program, it does also give local resources for where to get this reliable blood pressure units that we receive through the grant. And the monitoring, again, for a program to be successful in any health setting, there has to be a lead person, somebody that's committed to the mission to carry out, go through the barriers, communicate that back, and adjust and evaluate process on a consistent basis. And then we do have to make sure that we're maintaining the equipment, cleaning it correctly, and making sure that it works and is reliable. And the success is connecting patients with reliable equipment, increased patient engagement, and patients achieving the blood pressure control, which is going to lead to good outcomes, which were in all health settings. There's different outcomes that we're measured on, and it's important that patients have improved results with their blood pressure, which decreases other comorbidities that the patient puts himself at risk, and to keep the patient out of the hospital. And we did, like I said earlier, we haven't had a lot of patients enrolled in the program, but some of the ones that we have had for success stories, I included a couple scenarios. We had a patient that was on home care services for 4 months with severe COPD. And like I said, usually the primary diagnosis is not hypertension, but the patient is an underlying diagnosis. During that 4 months, the patient had a new diagnosis of glaucoma, which raised her blood pressure. She was started on a low dose of a blood pressure medication, and the provider wanted consistent blood pressure monitoring for this patient. The patient could not afford her own blood pressure monitor, so we, through this program, let her use one, and we were able to track those results, communicate those back to the doctor, and we were able to get her readings within a controllable level. And we did end up giving her that blood pressure monitor because she could not afford one, and she's been able to stay out of the hospital. And another success story, we had a patient that lived with her daughter. She had a very limited outcome, and the provider requested the patient keep a blood pressure log. Patient had an unreliable blood pressure unit in the home, and we see this frequently in the home care setting. Patients have units that are outdated, they're not maintained, and they're inaccurate, and providers will make adjustments, and they are not reliable readings. So because the patient had an inaccurate one, we actually gave her one through this program. She was started on a new medication. She was able to report back to the physician's office abnormal results, was able to record it, and through this grant we were able to give her a blood pressure cuff so she continues to stay engaged, and she communicates regularly with her doctor's office. So recommendations, takeaways that I have as a home care agency is assigning a key person for this program. It improves patient engagement, improves patient adherence, and provides staff and patients with access to best practices, evidence-based tools, and standardized resources. So I'm going to pass it over to Jen Adams.
Thank you. So I am a registered nurse at Mid-State Health Center. We're located in Plymouth and Bristol, New Hampshire. And I work out of Bristol.
Lydia, would you mind moving a little bit closer to the phone? You're just a little soft.
Okay. I'm also just getting over from a cold, so.
Thank you.
Yep. So I am based out of Bristol, but I'm seeing patients in both the Bristol and the Plymouth locations to enroll them in the SelfMeasured blood pressure program. And those are mostly patients that have a blood pressure reading of greater than 140/90 at some point, that usually have a diagnosis of hypertension. A couple of patients were interested in enrolling that had pre-hypertension. And then not necessarily criteria, but some of the reasons why patients were interested or the providers were interested was because they may have been making some adjustments to their medication, and also some of these patients learned of the program through our health coaching, which is what I do here, and as they're making lifestyle changes to see how that was impacting their blood pressure. So we started back in the fall, started having a conversation around October with my supervisors here about taking on this program, and we had the meeting at the very beginning of November with Georgette and Adriane to talk about getting it going at Mid-State and what was going to be involved, and shortly thereafter getting that procedure manual lined up and submitted and approved, and then undertaking the task of finding patients and getting them enrolled. And we received 50 monitors through this program to lend out. So we use something called I2I in our organization to do that search to see if we could find patients that were meeting some of the criteria for high blood pressure, and then having those lists basically go out to the providers to see if there were ones that they felt were appropriate or that would have that level of engagement to do this at home. So mid-December, we started doing that active recruitment and got our first patient enrolled in the program on November 16th. And when we're seeing patients, I'll usually see them in office for 30 to 60 minutes to do some education piece about the risk factors and lifestyle changes for blood pressure, and provide the educational instruction of how to properly check a blood pressure, have them sign a consent form agreeing that they're going to do this just measuring and call me with their averages on a weekly basis, and then also offer health coaching if that's something that they're interested in participating in. And by March, we had received our halfway point of distributing 25 monitors, and then mid-May was our 6-month data collection point that Adriane mentioned. And as Jen Gullison mentioned, having a lead person is really crucial. So this is just to show a little snippet of how I keep track, because not every patient calls at the same point during the week. Not every patient remembers to call every week. And I like to give them a little bit of leeway so that they feel like they're the ones that are self-managing this. But if I haven't heard from a patient in a month, I may check in on them just to see how things are going and what kind of challenges maybe they're facing, so, why they're not maybe able to call in as regularly. So having an Excel spreadsheet really just helps me keep on track of myself for that. And that also, part of that keeping track is then also getting that information, the blood pressure numbers, into their chart in our flow sheets, and also looking at what their goals have been set for their provider, by their provider, and if they're seeming to be jumping way up in their blood pressure, looking into that a little more about what might be going on, and doing care management as necessary around that. And this is just another example of a part of the Excel spreadsheet for just keeping track of the maintenance piece. So when those monitors went out, if they're returned, have they been cleaned, are they working, things like that. And we're going to talk about some success stories, and we have one of our patients here with us today, Tim, who's going to talk about this program from his perspective.
Hi, Tim. Are you on the line? Just use pound 6 to unmute yourself.
Okay.
We can hear you very, very faintly.
Okay, I'm going to pick up the phone handset.
Okay, yeah, you're crystal clear now.
Okay. I actually had gone to my primary care physician in January, and my blood pressure was elevated more than it had been. I think it was 150 over 90 something. So I started going to a health coach. It was, let's see, Chantal LaPlante at Midstate in Plymouth. And a couple times I went there, it was even higher. It was 160, 170 over 100. So I was a little concerned, and I felt some of it was stress-related, but I was concerned. And she did some suggestions as far as salt intake and exercise, which I have implemented. I have not salted my food probably since February. My wife even notices that. And so with those behavioral changes in March, I decided to go into the monitoring program. So we got the machine, came home, and I started monitoring my blood pressure. Generally, I tried to do it at different times of the day, sometimes a couple times a day or 3 times a day, other times just once a day, early morning, mid-morning, early afternoon, later afternoon, evening. Over a period of time, and I know I started doing it, I think the first day they did it was mid-March. First week was probably around March 18th, and I've been doing it ever since. And some of my early readings were like 156 over 98, 149 over 95, 152 over 96, 150 over 91. Then gradually, over a period of time, they started dropping. So, for instance, recent readings in the last 3 or 4 weeks, and these are just scattered, 132 over 76, 136 over 79, 139 over 82, 137 over 84. So they've dropped into the 130 over 80 range, give or take a few points. So I thought that was a considerable improvement. If you hadn't had the program, I don't know if I would have gone out and bought a machine. Maybe I would have. I'm just not sure. But when Chantal offered it and said it was available, I decided to do it, and I think I've been pretty faithful at calling in my numbers, at the average of my numbers, every Friday to Jen. She usually gets a voicemail from me if I don't connect with her. And I think part of the success really has been that they also was focused on some of the behavioral changes I needed to make, and the salting of the food was a big one, and the exercise, I got into a more formal exercise routine. My wife just retired, and we now walk. We've done it about 4 days in a row. She just retired last week, and we walk 2 miles every morning, first thing we do after we get up. I've been doing a little bit of treadmill before and some shorter walks, but this is a little more, and hopefully that will even help more. Because I am trying to lose a little weight, and I had lost maybe 4 pounds, 4 or 5 pounds, early on in the program, and I could lose another 10, to be honest. So the program's worked well for me, and I faithfully take it, and I follow the directions on how I put the cuff on my arm, and I sit in the same place. I do it in the same place on our living room sofa next to a table where I have the machine, and, I try to sit and relax, and they told me not to take it after you drink coffee and not right after you eat, so I'm very good about doing that as well. And I try to do a variety of different times, so it's not always taken in the morning or the afternoon. It's a mixture of times. So that's what I can say so far, and it's worked well, and working with a health coach has helped me make a few changes as well. So I think that's about it.
Thank you, Tim. And I will say you are one of my rock star participants as far as your consistency in calling in every week, and it's really appreciated.
Well, I appreciate the fact I had an opportunity to do this, and especially with my wife just retiring and me close to retirement, we're looking forward to doing some things, and so we want to keep our health up. So this was certainly a good way to do it. So I appreciate the opportunity to have the chance to do it.
Yeah, and I think we, likewise appreciate having the opportunity to be able to get patients into this program and have these types of success stories. A couple other ones, if I can share really quickly, for some success stories. We had one patient that came in, and her average blood pressure when she signed up was about 150/90, and for whatever reason after that, and some of that might have been stress related, I think she was switching jobs, she jumped up to averages of high 180s/90s and was quite concerned. And over a period of several weeks and going back and forth with her provider and making some adjustments to her medications, she was able to get her blood pressure average back down into the 130s, 140s range over 70. So she's really happy with that outcome. And then another really cool thing that happened with the same patient is that her husband checked his blood pressure at home out of curiosity, just wanted to use the machine, and it was pretty high, almost 170/103. And this really surprised him. He hadn't been in to see a provider in some time and didn't have care established, so we were able to get him in promptly. Actually, with our chief medical officer, she saw him that day or the next day. It was high in the office. She got him on to an antihypertensive, and he's come down since then to an average of 130s/80s, and I think in the last couple of weeks he's even had some as low as 120s. So they're both really happy with the program, and the first patient really, when we talked about it, she felt that this had probably saved his life. And then one last one is another patient that had been, high to begin with, 150s, 140s/70s and 80s. And she also, a few weeks into the program, jumped up really high, 190/80s. And in talking with her, it turned out she had run out of her medication. At some point along the way, they had been put into our system to fill at a local pharmacy instead of through the mail program that was allowing her to get them at the cheaper rate when you get a 3-month supply. So we were able to get that sorted back out again, straightened out, get her back on her medication, and now her blood pressure is back down to her baseline of 140s/70s. So Adriane touched on this briefly at the 6-month program data point. We had 34 patients that had received the blood pressure monitors. We've actually had a few more sign up since then. And at the 6-month point, 28 patients were enrolled and actively participating. So after we handed them out, a few people have returned them, and a couple of those didn't really give an explanation of why the program wasn't working for them, unfortunately. And overall, we saw 25 patients that had an improvement of their blood pressure. And of those, 16 patients are now below 140/90, where they started out above that. So some challenges that I've come across, the first one being patient recruitment. Just kind of at the beginning doing cold calls to patients based on that I-to-I search. It didn't seem to be as effective as when providers connect with patients at the time of their appointments and make the recommendation and let them know that there's this program and that I'll be calling them. And so doing outreach to the providers was definitely helpful as well as far as getting them engaged to be able to provide the information to their patients about this program. We also noticed increased patient engagement when they're working actively with a health coach. And those patients, because we're having more frequent contact with them and some face-to-face contact with them versus just phone contact, I think that just helps keep them engaged with their care. We also sent out a newsletter in the spring just to keep patients feeling involved and that they're part of this program. And one other challenge I've noticed is math literacy for patients that need to average their blood pressure. And so when we set them up with the monitor and do the patient education piece, we are giving them instructions on how to average their blood pressure. And for some patients that still struggle around that area, then generally I just have them either mail me their log sheets or leave a message with all of their blood pressure readings, and I just do the averaging for them. And this is just a quick snapshot of the newsletter we sent out this spring. And we included in that the different things that they can do, just to reiterate, lifestyle changes that they can do to improve their blood pressure. And that's it for me.
Thanks so much, Jen, and thank you to all of our presenters. It was, they all were fantastic presentations. At this time, we can take some questions. If you'd like to ask a question, you can post your question in the chat box. Just make sure to send it to all participants. Or you can press #6 to unmute your line and ask a question over the phone. While we're waiting, I know there was a question from Devin in chat. I think to Jen Gullison. Can you share the patient education resources and education tools used?
This is Jen Gullison, and I certainly can do that.
Jen, if you want to send them to me, I'll make sure that they go up on the event webpage where the PowerPoint presentation is, or I can always just send it out in the email to registrants.
Okay.
And this is Adriane Burke. Devin, I encourage you to look at some of the resources that I shared. So the Million Hearts Guide and the American Medical Association, Johns Hopkins Guide, they have some really great resources in there as well.
Thank you, Adriane and Jen. Does anyone else? Devin said thanks. Does anyone else have a question? #6 to unmute your line. There is a question in chat from Suzanne. Were most of the participants in the programs new to medication? I'm not sure who wants to take that one.
Some patients, I guess, were newer to taking medications, where they, like in the instance where the gentleman had a really high blood pressure in that success story. So for him, that was new. For some patients, we saw medication adjustments or changes to their medication where whatever they were on before just didn't seem to be working well.
Thanks. Susan Flynn asks, how many hours per week would you say your leaders devoted to this project? I'm not sure if anyone wants to take that one or if everyone wants to answer.
So this is Jen Gullison from Cornerstone DNA. Because we don't have high volume that's out for the units, it might only take her maybe a half hour a week. But I know other clinics, other health settings might have more because they have more units out.
And it really depends. This is Jen at Midstate. It depends on the week, and it depends on, it seems like it ebbs and flows where I'll have, a bunch of appointments to set up to see patients. And again, if those appointments are 30 to 60 minutes each, kind of getting, the monitor ready ahead of time takes a little bit of work. And then it depends on the week for the follow-up. So, some weeks are different than others as far as how many patients are leaving messages on my machine and getting all that information put into their chart. And then probably once a month I look through and see, okay, who haven't I heard from in some time? And I might block out a couple hours just to make follow-up phone calls to do that piece.
Thank you both. Julie Campbell, thanks so much for this presentation. On one of the beginning slides, it was mentioned that coverage for the blood pressure units was spotty. Do you have any advice to share about how to identify low-cost or free monitors? Not sure if anyone wants to take that one.
Hi, this is Adriane. That was one of my slides. So I don't have any advice on how to identify low-cost and free monitors. I'm trying to work with Medicaid in the state to see if they cover monitors, and I think that they do under certain circumstances. So I definitely think it's worth looking into coverage with them and see if they can cover monitors for your patients.
And I get the sense, this is done at Midstate, that some insurance companies are starting to cover if a patient is enrolled in some sort of a home monitoring program. So I think it may be Harbor Pilgrim that we saw as one of those, that they had put that out in a newsletter.
Thank you, guys. Another question from Justina. Are the RN or nurses the only people who deliver and work with the patient?
So this is Jen Gullison from Cornerstone. So we have both of our nurses and our therapists, actually, that will do those. We have therapy-only cases like the orthopedic patients that might have uncontrolled hypertension, and they are included in this model as well.
Thank you.
And at Midstate, it's the nurses that are working with, and specifically the health coaches that are working with the patients on this.
Awesome. Does anyone want to ask a question over the phone? It's #6 to unmute your line. While we're waiting more, before we wrap up, is there anything else that any of our presenters or Georgette would like to add?
Hi, it's Georgette. I just wanted to add that if you want to do something like this, I'm happy to come to your practices and do a lunch and learn around taking a blood pressure correctly, and also the SelfMeasured program. My contact information is in the slides, so reach out. This is a great way for you to get some points with MIPS, and I know that that's on everybody's mind this year as well. Thanks.
And this is Adriane.
Oh, go ahead, Adriane, no problem. Go ahead.
This is Adriane, and I forgot to mention in my presentation that we had a great relationship with Georgette, and she was able to make it out to a lot of clinics and work through the procedure document and how the program was going to look, and so she's been an invaluable resource. So definitely take her up on her offer if you're thinking about starting a program.
And I would agree. This is Jen at Midstate, that Georgette, both of you were a really good resource in helping as I was just starting here at Misty, and this kind of just got placed on my table because I had the extra time and I didn't have a large teaching caseload yet, so I just kind of ran with it, and it was helpful having somebody to go to with questions.
Great, and it's Olivia. I just wanted to add, for ease of Georgette's contact information, I'll also make sure to include that in the follow-up email that I send everyone, so you won't have to go through the slides either. All right, well, if there's no more questions or comments, I think we can wrap up. I just want to thank everyone for a great discussion. Just a few last-minute announcements before we end today. As you can see from the slide that's currently up, we're on social media. Please connect with us on Facebook and or LinkedIn for the latest resources, webinars, and other offerings from the New England QIN-QIO. When you close out of this webinar, an evaluation will automatically pop up on your computer. If you could please fill that out, we'd really appreciate it. If you don't have time to fill it out right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow with a link to the eval as well as the link to the event page on our website. I'll also include the resources as well as Georgette's information. The PowerPoint was in your day of details email, and again, it'll be posted on the website. And within a week, our recording and transcript of the webinar will also be added. So thanks everyone for attending. Thanks to our presenters, and I hope everyone has a great day. Thank you.
Thank you.